Good morning. Let me present myself. I'm Dr. Amir Ramadan from the Ophthalmology Department. My lecture today is about the ocular trauma. How do we classify ocular trauma? Ocular trauma can be classified according to the object and according to the effect. It can be caused by a blunt object or by a sharp object. And the effect can be a closed globe injury or an open globe injury. So if it is caused by a blunt object that causes a closed globe injury, we call it an ocular or a globe contusion. But if the blunt object is so strongly affecting the eye, it can cause what we call open globe injury, ruptured globe, in which there is a marked increase in the intraocular pressure, causing the globe to give way in its weakest point, usually at the rhombus, and as an inside-out force. If the trauma is caused by a sharp object, if it is just lamellar laceration, it is a closed globe injury. But if it is penetrating wound for thickness inside the eye, it is an open globe injury. This can be a penetrating injury, which is caused having a single inlet wound, or a perforation where there is an inlet and exit, and usually it is associated with an intraocular foreign body. First, we'll speak about the blunt trauma and then about the sharp or penetrating injuries. What is the blunt ocular trauma? Blunt ocular trauma, what's its definition? This is a trauma caused by a blunt object. This could be a fist, a stone, a small ball like a tennis ball, a baseball, a racket ball. How do we assess a patient presenting with a blunt ocular trauma? There is a history and there is an examination. The most important things in the history, you should know the mode of the trauma. Was it a quarrel? Was it an accident? And you should know the object causing the trauma. As we said, it's a blunt object. And the most important thing, this patient is coming probably having trauma in multiple areas of his body. So you must do ABC. You must check the patency of the airways, the sufficient respiration, and the effective circulation, and the consciousness level, because he may be having a serious problem, and you may miss it and threaten the life of the patient. Remember, a life-threatening condition like an internal hemorrhage or a pneumothorax must be managed first before managing ophthalmic problems. And if there is a minor ophthalmic procedure, it can be managed in the ICU. You don't have to postpone everything till the patient is transferred to the ophthalmology department. If he's having an animal bite, you must check his tetanus vaccination. You must ask about a drug history because he will be given medication in the ward. And if you can have, if the patient is conscious enough, you must ask about a full ophthalmological history, including previous eye trauma, previous eye surgery, and previous eye medications. The examination. When you examine the patient of the trauma, you need to evaluate two things: the extent of the trauma and the effect of the trauma. So how many structures in the eye are affected and how much are they affected. From these two items, you will determine the visual prognosis of the patient and determine the medical legal aspect of his condition. The examination, what do you examine? You examine the visual acuity of the patient, the pupil reaction and the pupil size, the extraocular muscle motility if there is diplopia, and whether it is in one eye or in both eyes, when he look with one eye or when he look with both eyes. And if it is possible, you can put him on the slit lamp and examine the anterior segment. Remember, you have to examine thoroughly, record precisely, and manage properly all the injuries in the eye. But what tissues do we examine? Remember that we have a bony orbit, and then surrounding soft tissues, we call it the adnexia, like the lid and the retinal system, and then we have the eye itself. So trauma can affect the orbit, can affect the lid, and can affect the eye. The eye itself can be divided into three areas: the ocular surface, which are the cornea, conjunctiva, and the sclera, and then the anterior segment, which is mainly the anterior chamber, the iris, and the lens, and the posterior chamber, including the vitreous, the retina, the choroid, and the optic nerve. So we will speak about the effect of trauma on each of these structures. First, the orbit. Two important things can happen in the orbit and affect the eye. The first is orbital floor fracture. We call it blowout fracture. It is defined as fracture of the orbital floor in which the lower orbital rim is intact. Under the floor there is the maxillary sinus, and the orbital cone tissue may herniate inside the maxillary sinus. If there is entrapment of the inferior rectus, there will be limited elevation of the eye in vertical up gaze. And also, if there is excessive entrapment of the orbital tissue, there will be apparent enophthalmos of the eye. In these two conditions, we will need to intervene surgically to separate the entrapped tissue and repair the floor of the orbit. The second complication is retrobulbar hemorrhage. It is a rapidly progressive, sight-threatening emergency. Okay, it occurs why? Due to accumulation of blood in the retrobulbar space. The accumulated blood will cause elevation in the ocular pressure, stretching of the optic nerve, and this may cause central retinal artery or central retinal vein occlusion, and this will cause complete loss of vision. So it is an ocular emergency. The patient will present with severe pain, proptosis, limited ocular motility, and loss of vision. And there may be other signs of hemorrhage like hematoma in the lid and subconjunctival hemorrhage. Because it is an emergency and it is a sight-threatening condition, it should be managed rapidly within 2 minutes of the onset. How do we treat it? We do lateral canthotomy and cantholysis. What is lateral canthotomy? We bring an artery and we clamp the lateral canthus. It is the junction between the upper and the lower lid for 60 seconds. And then we use a scissor to make an incision, horizontal full thickness incision, 1 to 2 millimeter. Then this is canthotomy. Then we do cantholysis. We pull the lower lid downward like this, and with the scissor we cut the lower part of the lateral canthal tendon with the scissor directed inferiorly and parallel to the lateral orbital rib. And then we allow the blood that is collected behind the globe to exude or to evacuate anteriorly, and we give systemic acetazolamide to decrease the intraocular pressure. So we spoke about the orbital, the heart tissues surrounding the globe. Second, the soft tissue, the lid. What can we have inside the lid as a problem? First, we can have hematoma, which is due to bleeding in the soft tissue of the lid. It's a solid swelling. And as we see in this image, we can have ecchymosis. Ecchymosis is just bleeding inside just below the skin without swelling of the skin of the lid. And we can have surgical emphysema. Surgical emphysema occurs when there is trauma of the ethmoidal bone, which is the medial wall of the orbit, and the air in the ethmoidal sinus enter into the tissues of the lid, and there is crepitus. When you press on the lid, you feel the sensation of air inside below your hand, and it increases with blowing of the nose, and usually it is self-limited, it improves by itself. Lastly, in the lid there is lid lacerations. Lid laceration can be just a skin wound which will be sutured, but the two important conditions: if it involves the lid margin, we call it a cut lid, and we have a separate repair to reconstruct the lid margin, and it may involve also the lacrimal puncti and caniculi, which is canalicular laceration, and it needs intubation to restore the canalicular pathway so that the patient doesn't have post-operative epiphora. So now we enter into the anterior, the ocular surface. We start with the conjunctiva. We may have a conjunctival laceration, as we see in this picture. There is gapping of the conjunctiva from the object, from the blunt object, or we may have subconjunctival hemorrhage, as we see in this picture, traumatic subconjunctival hemorrhage. Probably both of them are self-limited and doesn't need any special management. But remember, if you have a subconjunctival hemorrhage with a very low intraocular pressure and a deep anterior chamber, you should suspect the presence of an ruptured globe or full thickness wound, either hidden below the hemorrhage or posterior rupture in the posterior pole of the globe. Cornea. We may have epithelial defect or an abrasion of the cornea. How do we know there is an abrasion? We put a sterile fluorescein eye drop, and as we see in the image, we look at the eye with a copper blue light. The area of the abrasion will get staining by the fluorescein in this green color seen in the blue background. We may have also corneal laceration. As we said, they may be lamellar or full thickness. Full thickness, it is an open globe injury, but we speak about it here so that we know what we will find in the cornea. This laceration will be associated with the shallow anterior chamber or iris incarceration in the wound if it is full thickness laceration. And also the blunt trauma may cause just endothelial injury, which will, as you know, the endothelium is the bomb that keeps the cornea dry, so the patient will only present with corneal edema without laceration and without abrasion. The sclera, we may have scleral laceration, and as you know, if there's full thickness, you will have the choroid coming out of the wound and will have to be surgically repaired. The anterior chamber, we will comment on two things in the anterior chamber: the depth and the content. The depth. The anterior chamber may be abnormally shallow or abnormally deep. It can be abnormally shallow in two conditions: if there is a corneal laceration with loss of the aqueous, so there is shallow anterior chamber, and you find the cornea in front of you, or if there is intumescent cataract, the lens has cataract and it's swollen and it is filling the anterior chamber, especially if there is open wound and lens matter coming out of the lens. The anterior chamber may be deep if there is scleral laceration, not corneal. So corneal causes shallow anterior chamber. Sclera, there will be herniation of the ciliary body from the scleral laceration, and all the content are going backward. Also, if there is anchor, here is the first photo showing into corneal laceration with shallow anterior chamber. As you see, the light beam of the cornea and of the iris are so close to each other, which means the anterior chamber is almost lost. In the other photo, we have a deep anterior chamber caused by angle recession, which is defined as a mild disinsertion of the iris root. How do we know it? In this photo, we do conioscopy. We see the area of the ciliary body and it is widened, broadened. So there is broadening of the ciliary body due to partial separation of the iris root, and this may result in later glaucoma. Remember to separate angle recession from iridodialysis, which is total disinsertion of the iris root, which results in an irregular depth of the anterior chamber, and as you see, there is a D-shaped pupil and a defect at the area of the iridodialysis. So we spoke about the depth of the anterior chamber. Now we speak about the content. We may have two things in the anterior chamber: hyphema and hypopyon. What is hyphema? Hyphema is hemorrhage in the anterior chamber. What is the source of this hyphema? Usually it is bleeding from the vessels in the iris root. How does it behave? The blood will settle inferiorly, causing a fluid level. As you see in this picture, it is not called hyphemia, it is called hyphema. Remember, there is a condition called 8-pole hyphema when the hyphema is total. Why do we call it 8-pole hyphema? Because there is deoxygenation of the blood in the anterior chamber, which becomes dark in color, resembling the 8 black ball of the billiard, and it carries the highest risk of the complication. What are the complications of the hyphema? Why are we afraid of it? Because there is a problem of rebleeding. If the rebleeding occurs, it may result in further complications. Usually bleeding highest incidence in the first 5 days, and if rebleeding occurs, more blood accumulates in the anterior chamber, resulting in increase in the intraocular pressure, and then this blood may enter the cornea, causing corneal blood staining, which is an irreversible condition. The cornea becomes brown in color even after resolution of the hyphema, or the high intraocular pressure may result in central retinal artery occlusion or ischemic optic neuropathy. This is the photo of the 8-ball hyphema. How do we manage it? First, the patient should be hospitalized. There is a medical treatment and a surgical treatment. The medical treatment, the most important item in its management is complete bed rest. Better he sleeps at an angle of 45 degrees so that the hyphema doesn't circulate in the anterior chamber but keep settled inferiorly. We gave him cycloplegic to decrease the contraction of the ciliary body and the iris, which may dislodge the impulse and cause rebleeding. We gave him topical steroid to decrease the intraocular inflammation, and we gave him IOP lowering medications if the tension is high. If the tension keep high in spite of all this treatment and there is rebleeding, we turn to the surgical management, which consists of evacuation of the blood in the anterior chamber. As you see in this photo, we do irrigation aspiration and aspirate the blood, and if the clot is tough, we may use a cutter to eat it in the anterior chamber and remove it. And if the tension remains high, we may even do surgery for lowering the intraocular pressure. The other content is pus in the anterior chamber, which usually occurs in neglected open wounds. So it is a part of the open wound, but we're discussing it because we are doing here the systematic evaluation of all structures. Usually it is called post-traumatic infectious endophthalmitis. The iris and the pupil. So we have finished the ocular surface, we are entering in the anterior chamber, the iris and the pupil. The first thing we may find is iridodialysis. As we said, it is local separation of the iris root from its attachment to the cellular body, and as a result the pupil will appear D-shaped, as you see in this picture, instead of the normal circular rounded appearance. Another problem is traumatic aniridia, in which there is complete separation of the iris root, not from a localized area, all over. All the iris is separated. Probably, if it is an open wound, it goes outside of the globe, or it is fall into the fundus. And as you see in this picture, there is the iris present, but there is no iris present. Other of that, the trauma can cause traumatic iritis and traumatic mydriasis, which is common, and it occurs due to sphincteric tears. As you see in this picture, there is irregularity of the pupillary margin due to tears of the sphincter pupillae, and this results in dilated pupil. Also, traumatic miosis may occur. Iris atrophy may occur, which is a late finding, doesn't occur in the early stages of the trauma, or iris prolapse if there is a corneal laceration, as you see in this picture. The IOP is very important. If there is severe hypotony, you should exclude an occult open globe injury, as we said. And if there is elevation of the intraocular pressure, it may be due to hyphema or due to inflammation. Remember that the angle recession we talked about previously, which results due to damage of the anterior part of the cerebral body, can result in late secondary open angle glaucoma. So even if the patient doesn't have rise in the temperature in IOP early, you must follow up this patient because he may later develop angle recession glaucoma. The lens. The first change, you may have imprint of the iris pigment on the anterior capsule of the lens, as you see in this picture. When due to trauma, the pupillary margin presses on the lens, and some of the pigments remain on the surface of the lens. We call it Vossius ring. All traumatic cataract, if the trauma affects mainly the lens, and because the trauma is high, there may be disinsertion or tear of the zonules. May have lens subluxation or dislocation. Just subluxation, it is slightly moved to one side, and dislocation, if it falls completely in the posterior segment of the eye. Vitreous. You may have posterior vitreous detachment, in which there is separation of the vitreous from the surface of the retina, and this may be associated with floaters and flashes. And with separation of the vitreous, it may press on a retinal vessel, resulting in vitreous hemorrhage. And if this traction is strong also on an area of the retina, it may result in a retinal break over a blood vessel, as you may see here. This is vitreous hemorrhage, and this is retinal tear on a blood vessel. And this tear, if not managed accurately, promptly, may result in retinal detachment. So we may have a sequence of events: posterior vitreous detachment resulting in traction on a vessel, vitreous hemorrhage, and traction of the retina, retinal tear, and retinal detachment. Also, we may have rhegmatogenous retinal detachment. As you see, there is a break and retinal detachment without vitreous hemorrhage. Commotio retina is another finding in the retina, in which there is cloudy swelling of the retina, giving an area of gray appearance. The involved area will have a gray appearance instead of the normal transparent retinal appearance. And if there is hemorrhage in the macula, we will have a shady red spot. Retinal dialysis, if there is retinal break just at the ora serrata, the most anterior part of the retina, we call it retinal dialysis, and this is very common with fist trauma. And traumatic macular hole is a full thickness defect, as you see in the foveal area, and as you see, there is associated RPE atrophy, which occurs in trauma, and it is a sign of traumatic macular hole, and it is a bad prognostic sign. The choroid, we may have choroidal rupture, which usually involves the choroid, the buccal membrane, and the retinal pigment epithelium. Sometimes the patient has hemorrhage, and when the hemorrhage absorb, we find the vitreous, the choroidal rupture. Or when we do vitrectomy and remove this hemorrhage, we find the choroidal rupture. It appears as a white crescent, as you see here, white crescentic streak of exposed sclera. and if it involves the fovea, it has a bad visual prognosis. So the patient is unlucky if you do for him vitrectomy for vitreous hemorrhage and you find a choroidal rupture involving the fovea. Optic nerve. The trauma may cause traumatic optic atrophy, optic neuropathy. As you see in this picture, the patient has edema and hemorrhage from the optic disc, and this patient should be managed as an emergency with intravenous methylprednisolone to minimize the damage affecting the eye, and even with that the prognosis is still poor. We may have traumatic optic atrophy, which is a late finding. As you see, there's a white disc in both eyes. And we may have optic nerve avulsion from the globe, separation of the optic nerve from the globe, and a defect at the side of the optic nerve. And this was a severe trauma that pulls the eye suddenly to one side, and this has no treatment. Globe rupture. Remember, as we said, that if a blunt trauma causes an open globe injury, we call it a ruptured globe. If the blunt trauma caused a closed globe injury, we call globe contusion. The ruptured globe means the trauma is much severe, so the prognosis is probably worse than the closed globe injury. And if the visual acuity is perception of light or no perception of light, this is the worst prognosis. The globe giving way will result in prolapse of the content of the eye. Probably those of the anterior segment, like the lens, the iris, the cerebral body, and the vitreous. And we will need to do imaging study to confirm our diagnosis. There is another condition which is not common in pediatrics. It is called shaken baby syndrome. When child below 2 years of age is shaken heavily, probably the caregiver of him cannot withstand his crying, so it's shaking him a lot. Acceleration deceleration injury may cause hemorrhage inside the eye and cause brainstem injury, and this has a high rate of mortality. 25% of these patients die, and is a form of child abuse. The brainstem injury will cause apnea, which will result in hypoxia and increased intracranial pressure, and this would be the cause of the death, not the direct trauma. How do we diagnose this patient? The patient usually comes with irritability and vomiting. You misdiagnose with gastroenteritis, and systemically you may find signs of trauma or no things at all, and only findings are present in the eye. You will have retinal hemorrhage, usually bilateral, and subconjunctival hemorrhage and poor pupillary reflex. As you see in this image, right and left retinal hemorrhages, while the other image is a normal fundus appearance. Now we have spoken about the blunt ocular injuries. Now we'll speak about the penetrating ocular injuries. Remember that, as we said, there is a closed globe injury and open globe injury, and those caused by sharp object can be lacerations, penetrating injury, or perforating injury. Laceration is a full thickness defect in the eye wall produced by a tearing injury, usually as a result of direct trauma, like a knife, a piece of glass cutting the eye. Penetrating injury usually have a single full thickness wound caused by a sharp object without an exit wound, like a syringe entering in the eye. It may be associated with an intraocular foreign body inside the eye if it is just penetrating injury, like a bullet. But perforating injury, like someone has cutting a metal, the foreign body may enter in the eye, it is a penetrating injury. But if it's a hit by a missile, like a shot, it has a very high velocity, so it may enter and exit the eye. In this case, it is called a perforation. We have two full thickness wounds, one entry and one exit. The incidence, it is more common in male, especially in the young age. In the United States, it is common between 15 and 34 years of age. The most common cause is an assault or an occupational accident. How do we investigate? Investigation is important here. We need to do an X-ray first. A metallic foreign body will be seen in an X-ray. How do we know it is inside or not inside the globe or outside the globe? We take two radiographs, one with the patient looking downward and one with the patient looking upward, and we'll see movement of the foreign body. So it is inside the globe because it moves with the movement of the globe. Second, we do CT. It is better than the X-ray in detection and in localization of the foreign body, and we can do MRI. it is better than the CT in assessing the injury of the probe itself. But remember, if it is a metallic foreign body, it is contraindicated, especially if suspected is an iron. It is contraindicated to do MRI because it is a magnetic field. It will cause movement of the foreign body inside the eye and causing further damage. How do you manage the patient with open globe injury? As in the blunt trauma, the ABC first of the trauma, and then you must cover the eye with a rigid eye shield to prevent further trauma. You should not press on the eye, you should not measure the intraocular pressure, and you should instruct the patient on NPO, nothing, nil per os. He should stop any food or drink because he will need to be urgently operated upon for this open globe injury. Remember, as we said before, post-traumatic infectious endophthalmitis increase in two conditions. If there is delay in the repair of the wound beyond 24 hours, so it is an ocular emergency, as soon as possible we must repair the wound to prevent the endophthalmitis. And also if there is a presence of intraocular forebody, this also increases the possibility of infectious endophthalmitis. We have a rapid speech on the intraocular foreign body because it's an important finding in the eye. As we said, first it can cause a perforation or penetration. It may have an inlet and stay inside the eye, or it may have an inlet and exit. In penetrating trauma, it is quite common. Up to 40% of the cases may have an intraocular foreign body, and the risk of intraocular foreign body increase with metal on metal tasks, not wearing eye protection, and in male patients. Most patients are also like the penetrating ocular trauma between 20 and 40, and most of the foreign bodies reach to the posterior segment, and metallic foreign body are the most common intraocular foreign body. How does it affect the eye? In two ways: by the direct trauma via its entry in the eye and the tissues it's hit, and also by its composition. The iron will cause what we call siderosis bulbi. It will cause rust inside the eye, and it will cause destruction of the photoreceptors and marked diminution of vision. And the copper will cause what we call calcosis bulbi, in which there is severe intraocular inflammation like endophthalmitis and sunflower cataract. If the intraocular foreign body is an organic material, like a vegetable, it may cause severe tissue reaction, and because it is probably highly contaminated, it may also result in endophthalmitis. Remember, when taking the history, to check if it is unilateral or bilateral, because explosive and firearm usually cause bilateral ocular damage and multiple intraocular foreign bodies in both eyes. Look for the inlet of the foreign body. You must check four sides. A scleral entry site, it may be present in area of conjunctival hemorrhage or conjunctival chemosis or conjunctival injection, or an entry into in the cornea, entry side in the cornea. There may be area of corneal edema, and inside there is a defect in the cornea. And if you do a Seidel test, as you see here, we put fluorescein and look on the eye with a coupled blue light, and slight pressure on the eye, we will see trickling of the aqueous from inside the eye, so it is an open globe injury. Or you may see a small iris defect, which may indicate that the foreign body has entered through the iris into the cornea, and you may have a focal length opacity, which indicates also the area of entry of the foreign body. What is the problem of a foreign body inside the eye? It may result, as we said, in infection, endophthalmitis, as we said, also in traumatic cataract, and since about 88% may reach the posterior segment, you may have retinal detachment and vitreous hemorrhage. How to investigate? Like any penetrating trauma, we have plain X-ray looking for the foreign body. B-scan ultrasound, as we see, there is shadowing from the intraocular foreign body in the B-scan ultrasound, but it has a low sensitivity, so it can miss some foreign body. We must do also CT scan as a medical legal condition, and MRI if it is not a metallic iron foreign body. How do we treatment? The same assessment as in the blunt trauma of the eye. As we said, we should protect the eye with a protective shield and avoid any pressure on the globe. We give him broad spectrum antibiotic because it is probably a contaminated foreign body, and the definitive measurement is doing vitrectomy, as we see in this image, with removal of the foreign body, management of any retinal tear or retinal detachment, and probably intravitreal injection of antibiotic if there is suspicion of endophthalmitis. Finally, I would like to thank you for allowing me to give this lecture, and I want you to I wish you best of luck. Thank you.